Thank you very much for that kind introduction, and good morning, ladies and gentlemen. I'd like to start by thanking the organizers for inviting me to speak at this meeting today. It's very, very nice to join the second annual meeting of the Vietnam Atherosclerosis Society. So this is my title, and going forward, this is a more exhaustive list of my affiliations. This is my disclosure. Now, obesity is really the modern epidemic, and it's driving many of the problems of diabetes and cardiovascular disease. And this slide just summarizes all or many of the problems related to obesity. I won't go through all these. I think you're probably familiar with a lot of these things. Now, this was an interesting study of the genetics behind obesity using the UK Biobank data. So they do the Mendelian randomization, looking at SNPs related to BMI or SNPs related to fat mass index. And it's interesting, I think, and a bit surprising perhaps, that aortic valve stenosis comes out as the most important thing related to these SNPs. So I wouldn't have expected that, but maybe some of you are familiar with that. Of course, it's also related to lipoprotein little a, but I don't think that's nothing to do with this particular thing. So aortic valve stenosis comes out as the most important thing related to these two genetic markers of obesity, followed by heart failure. So it's not so much atherosclerosis, in fact. There are other things which are more obviously related to genetic markers of obesity. And of course, the management of obesity is very difficult. It does need a very strong team of people working together to try to overcome the problem of obesity in our patients. And here's another interesting study looking at the effect of gastric bypass surgery in patients with type 2 diabetes. So these people obviously had severe obesity to start with. And looking at the things which are most improved with gastric bypass surgery, it was the effects on the kidneys, macroalbuminuria, renal disease progression, and heart failure. So heart failure and renal disease, again, improved by treating obesity with bariatric surgery, whereas non-fatal cardiovascular disease down here was not improved to such a great extent. So again, it's interesting, these relationships of obesity treatment and outcomes. Now, a few years ago, we reviewed all the available anti-obesity drugs. This was at the time when liraglutide was just approved for the treatment of obesity, but all the preceding drugs were really not very effective and did not have any evidence of improving cardiovascular outcome. In fact, sibutramine had evidence of worsening cardiovascular outcome. So at that point in time, it was very nice to have liraglutide coming along. And of course, the liraglutide studies showed a very clear reduction in body weight. But this one didn't actually look at cardiovascular endpoints. But there were the cardiovascular endpoint studies when the GLP-1 receptor agonists were used for the treatment of diabetes. And in that one, liraglutide did come out positive, and then semaglutide and dulaglutide. So we had evidence in people with diabetes that treating them with GLP-1 receptor agonists for their diabetes was beneficial. And then of course, the SGLT2 inhibitors, particularly empagliflozin here, was very remarkable in reducing cardiovascular events. But when you look at the events that are reduced, it's largely heart failure, not atherosclerotic cardiovascular disease. And we again reviewed the effects of SGLT2 inhibitors and GLP-1 receptor agonists earlier this year. And of course, the GLP-1 receptor agonists are much more effective in reducing body weight, reducing HbA1c, but they have the slight disadvantage of increasing heart rate in some studies, and that may be not ideal in heart failure. On the other hand, SGLT2 inhibitors are relatively helpful for reducing body weight, but only to a slight extent. They don't affect heart rate. They have a peculiar effect on LDL cholesterol, increasing it slightly. And in fact, this study from Professor Nordesgaard's group examined all the trials looking at the effect of SGLT2 inhibitors and showed this slight increase in LDL cholesterol. Now, I'm not sure why that occurs, and maybe Professor Nordesgaard will explain to us afterwards, but maybe it's because of some hemoconcentration. You know, with the SGLT2 inhibitors, they do increase hemoglobin, hematocrit, and so I think there's a small degree of hemoconcentration. So, comparing these two treatments for diabetes, the GLP-1 receptor agonists do seem to reduce ASCVD, whereas the SGLT2 inhibitors improve heart failure and are now indicated for chronic kidney disease, with or without diabetes. So the GLP-1 receptor agonists seem to have a specific effect on lipids, acting through some neural networks involved in the absorption of triglycerides. And so when you start the GLP-1 receptor agonists, the triglyceride levels go down pretty quickly. And of course, nowadays, we're having multiple receptor agonists. We've had the GLP-1 receptor agonists now for several years, but now we have the dual agonist, tirzepatide, which has an interesting structure here, so that it not only activates the GLP-1, it activates GIP. And these two receptors have slightly different effects, as shown in this review from Michael Nork a few years ago. So although some of the effects are rather similar, they both increase heart rate slightly, but on balance they have very good effects overall. And nowadays we have potentially 3 receptors to target, not only GLP-1, but we have the GIP and the glucagon receptor. So we have a whole range of drugs now which are either dual agonists or triple agonists. And these do have different effects. And all these are being studied primarily in obesity, but also for fatty liver disease. So if we look at one of the recent ones with semaglutide, so this was in people without diabetes, a select trial for cardiovascular outcomes in obesity. And we can see some significant effects here with semaglutide. It's patients who have a BMI above 30 or above 27 with cardiovascular disease, and they're getting the high dose of semaglutide. There's quite a bit of discontinuation, but overall a very good effect, and a very good effect on these various lipid parameters here. So if we can look down here at the effects on total cholesterol and LDL cholesterol, particularly triglycerides. So we're getting quite a good effect on the lipid profile with this treatment with semaglutide, but of course very much related to the reduction in body weight. Now if we move on to the dual agonist, tirzepatide, here's the SURMOUNT-1 trial, which again shows a greater degree of body weight reduction than with semaglutide. So the mean change in weight here goes up to 20%, although when you subtract the placebo effect, maybe it's more like 17-18%. And the adverse effects were relatively infrequent, I think. And again, if we look at the effects on lipids, then there's a very good effect. This trial only was looking at the effects on body weight, not so much on cardiovascular outcome. But you could expect, you can anticipate that it will have a good effect on cardiovascular outcomes because of these changes in lipids. And again, most recently, the triple receptor agonists, so retatrutide, which is an agonist for GLP-1 and GIP and glucagon. Looking at the different doses here, you can see the changes in body weight over 48 weeks are very impressive. You're getting down to 24% reduction in body weight, which really is remarkable these days compared to all the old drugs, which you're looking at 5% at the most. So here, these patients with a BMI over 30 or over 27 with an additional risk factor are getting these really very impressive reductions in body weight with this drug. And again, if we look at the effect on lipids, it is really quite remarkable. Looking at the effect on triglycerides here, we're almost getting a 50% reduction in triglycerides, and also reduction in LDL, but not a very good effect on HDL. A bit surprising maybe, but I think on balance the reduction in all the atherogenic lipids are going to work out to reduce atheromatosis vascular disease very effectively. So these treatments, which started off with GLP receptor agonists and now the multiple agonists, I think are going to be the mainstay of treatment to reduce obesity and to reduce cardiovascular events. Of course, the downside is they're very expensive and not readily available, but my experience in Hong Kong and Macau, everyone wants to take them. You know, and I don't know what's available here in Vietnam at the moment, whether you have semaglutide and tirzepatide, but I'm sure it will be very expensive, not easy to obtain. So here's my conclusion. In the management of obesity to prevent atherosclerosis, some of these new GLP-1 receptor agonists are very effective. Semaglutide has reduced cardiovascular events already in patients without diabetes. Tirzepatide is even more effective in reducing body weight and cardiovascular risk factors. And the triple hormone agonist, retatrutide, is even more effective. So we're getting to the stage where we can give these drugs, we can reduce obesity very, very effectively, and we can improve cardiovascular outcomes. So I think the progress here has been really remarkable, and there are ongoing trials in all of these areas. So that's my quick review, and thank you for your attention.